Good evening. My name is Dr. Darren Nabor. Thanks for joining me tonight. Sorry, I'm having a little issue with my computer there. I'm a full-time orthopedic surgeon here at OSMS at the Appleton location. A little bit about myself. I'm an orthopedic surgeon. I did my residency training in Milwaukee at Frederick and the Medical College of Wisconsin. That's also where I did my medical school. After my residency training, I decided to do an additional year of sports medicine fellowship at Wake Forest University in North Carolina. When I was in Milwaukee, a lot of my training was focused on joint replacement, fracture care, hip and knee pain, and I elected to do an additional year of sports medicine training where I focused mostly on arthroscopic surgery, focusing on hip, knee, and shoulder pain. So I wanted to thank you all for joining me tonight. A little bit about us here at OSMS. We have a brand new building right here in Appleton. It's right off the highway. What's really unique about this building, the reason why I really wanted to practice here, is it's like a one-stop orthopedic shop. We have a bunch of clinic space for all of our patients to come in to be seen by a physician, but we also have state-of-the-art x-ray machines, an MRI machine in our clinic here. So a lot of the times we can see a patient the same day, examine them, try to figure out what their problem is, and actually get an MRI if we think it's the right move to go. We can get it done fairly quickly, which I think is a huge advantage, and it's been a really big patient satisfier. The other thing that is unique about our location here, upstairs, we actually have a full surgery center. So we have the ability to do all types of orthopedic surgery, including total joint replacement, and that would include total hip replacement, total knee replacement. We have 7 rooms that the patients can recover in overnight, and then everything goes well, they go home the next day. So it's a really unique practice environment for orthopedics, and our goal is just to have one building where you can pull up, park right in front, get seen by a physician, get your imaging, what you need there, and have surgery here if that would be the case, and you don't have to run around town. And I think it really has been a big patient satisfier. So today I was going to talk a little bit about hip pain. And I always like to tell patients kind of how I ended up in orthopedic surgery. We study all types of medicine in medical school, and you have the option to kind of become any type of physician you want. But I really enjoy orthopedics because most patients will come in with a specific problem, whether that be knee pain or hip pain. And more often than not, we can diagnose it right away with x-rays and imaging and exam findings. And I really like to get to know my patients, kind of to understand what their goals are, what they want to get back to doing, and more often than not, having a solution to offer them, whether that be conservative treatments such as medications or therapy, or sometimes even surgery. And I really like having a cut and dry type practice where I can really give my patients options and get them back to doing those things they want to do as soon as possible. One quick question before I started too. This has been something that's kind of come up over the months because of the COVID pandemic. We often get asked, what are we doing to keep our patients safe here? We've implemented social distancing. We really try to limit visitors just to only the patient and the actual, family members that have to be there. Everybody's still wearing a mask in our clinic building, including the doctors, nurses, and all the patients. We're using extra sanitary measures to make sure everything's nice and cleanly. We were requiring patients to have a COVID test before surgery to ensure that we were preventing anybody from COVID entering the building that was going to have surgery. But now, if you are immunized, you can actually proceed with surgery without having that test, which has been really nice too. So we've really tried to go above and beyond to keep our environment safe and protective for our patients. So tonight, I already have some questions that we'll go over, but I really wanted to kind of just give a brief introductory to hip pain. It's a very broad topic, and by far and away, one of the most common things I see in clinic is hip pain. So I want to kind of go over the most common types of hip pain today, really what the anatomy of the hip is, just so you guys get an idea of what we're talking about when we show your x-rays and we're kind of moving your legs, to have an idea kind of what we're looking for. So the hip is very complex, and as you all know, it's very close to other anatomic locations such as the back, other reproductive organs in the body, and a lot of the times hip pain can be mistaken for some other type of pain, and that's where an orthopedic surgeon, I think, really can help out. So just a little bit about the anatomy of the hip joint. Here's just a plastic model. And this is the hip socket right here. You can see this is what we call the acetabulum. It's a deep socket that's bony, and it's attached to the pelvis. And on the outside of that socket, there's a piece of labral tissue called the labrum. And that just essentially is a thick piece of cartilage that deepens the socket and keeps the hip stable. And it's a common area that can actually get injured. So you can see the socket here. The femur bone sits right deep into the socket, and it creates the hip joint. So there's a lot of motion there. The hip can be flexed, it can be brought out to the side, inside, or even rotated. And this is the femoral head, so that's the other part of the hip joint right there, you can see. And usually the femoral head and the cup of the hip, the acetabulum, those are the two areas that are covered in cartilage. And cartilage is that shiny surface, that smooth surface that allows hips and knees and shoulders to glide nice and smoothly over each other and not have pain. The other area, the hip, that we kind of talk about is this bony prominence right here. This is called the greater trochanter. You can see it's that bump, and it's outside of the hip joint. There's a lot of important muscles that attach right here to this bone, and that can be a common place of pain as well. So really, when we talk about hip pain or the hip joint, we're talking about the ball and socket joint. And looking at x-rays, you also see, here's just an example of an x-ray here. The hip joint right here is where the ball and socket is, and that's where we see arthritis changes. And then there's the bump here, the trochanter we call it. That's where you can see pain from bursitis and stuff like that. So we'll go over that in detail today. But the thing I want to start with is hip joint pain and what is that symptom is, because it's hard to tell if you have hip pain. Is it coming from your back? Is it coming from the outside, the inside? And I'll tell you what, with hip pain, location is key. That's one of the most common things that we talk with our patients about when they come into clinic is, where's your pain? Can you point to it? Tell me what it feels like. And when we're talking about hip joint pain or the ball and socket joint, if that's the common source of the pain, the most common symptom that patients actually complain about is groin pain, deep in the groin region, usually right in the front of their hip region. And like I said, this can often be mistaken for some other type of pain, such as a hernia, reproductive issues, especially in females. So if you're having groin pain and you feel like it's sharp and it's kind of dull and achy, and you're kind of feeling it deep in that inguinal crease region, that most commonly is hip joint pain. And that's one of the areas that we'll talk about when you come to see a doctor is, where's your pain out, to kind of help identify if it's coming from the hip joint itself or the ball and socket joint. And the question is, older people have hip pain, younger people have hip pain. I see patients as young as teenagers, even younger, that sometimes that present with hip pain. And the way to kind of know what your symptoms are is usually kind of getting a sense of how old you are. I always tell patients, if you're above 50 years old, and if you're having pain in the hip and it's kind of in the groin region, more often than not, that's usually related from arthritis of the hip, or osteoarthritis, which we call. So the definition really of osteoarthritis is truly just the wearing away of that cartilage, if I was to pull the model out here again, of the ball and the socket joint. So as that ball rotates in the socket over an entire lifetime, just like a tire, the tread gets thinner and thinner. And that same thing happens to the hip joint, the cartilage. That cartilage just slowly wears out. And that truly is the definition of osteoarthritis, is the wearing away of the articular cartilage. And it can happen on both the ball side and the socket side, and sometimes it happens on both of them. And that's when patients start to have significant pain right in the ball and socket joint. And like I said, that's usually manifest as groin pain. So, I always tell patients, if you're above 50 and you're having groin pain, it definitely warrants x-rays. X-rays are usually the way we diagnose arthritis, and it's very quick. You stand up, a quick shot of your pelvis, and you can look to see if there's any significant wearing of the cartilage. And more often, that's all you need to help diagnose arthritis. And the question is, if you're having pain, you get x-rays, you're told you have arthritis. The most important thing is, how do you treat that? And there's a lot of treatment options. Usually we start very conservatively. A lot of the times, an anti-inflammatory, Tylenol, stretching, a round of formal physical therapy, working with therapists to kind of help strengthen the hip, can really make that pain get better. Another thing that we often use for hip arthritis or hip joint pain is putting a steroid injection right into the hip joint. And what we do is we usually use ultrasound or a x-ray machine where we'll help target that needle right into the hip joint and delivered that steroid. And it's kind of like putting a bunch of ibuprofen right in your hip. It has a huge anti-inflammatory effect. It can make you feel much, much better. And one of the other things I forgot to mention at first is if you guys have any questions, please write them out, and I'll try to answer them as I go along. So please just post them, and I'll do my best to get to them tonight. So we talked a little bit about arthritis. It manifests usually as groin pain. One of the most common questions I get is younger patients, 30-year-olds, 40-year-olds, even 20-year-olds come in, and they're starting to have hip pain. And they're not, I don't have arthritis, I'm 20 years old, there's no way. And a lot of times they don't. But young people still can have pain that's coming from the hip joint. That is not arthritis. So that's why I always say if you're kind of up about 50 or older, most of the time it is, but 50 or younger, you can have hip pain that is not from arthritis. And that's the other thing I wanted to talk to you about today. So part of my training when I was in fellowship was I focused on a diagnosis called hip impingement. It's kind of a newer diagnosis that we're learning more and more about in orthopedics. And essentially what that is some patients from their anatomy form an extra piece of bone on the front of their femur. It's called a cam lesion. And what happens, you kind of get this extra piece of bone right here on the femur bone, and when you start to move your hip around, it can actually impinge and get pinched on the acetabulum, or the cup of the pelvis bone. So when those two come together and get pinched, that can cause significant hip pain, and that usually also manifests in groin pain because it's coming from the ball and socket joint. So if you're younger and you're starting to have groin pain, obviously it's probably not from arthritis. Most commonly what it's from is a thing called hip impingement. And there usually is extra bone that forms on the socket of the hip and extra bone that forms on the ball of the hip. And when those two collide together and get pinched together, the two bones collide, and it actually causes tears of that labrum tissue that I talked about earlier. And that's just that cartilage tissue that goes right on the outside of the cup of the hip joint. And when those two bones come together and pinch together, it can kind of get caught in between it. It's just like sticking like a marble on a door jamb, and you kind of shut the door. It doesn't shut all the way because there's too much stuff in the door, and that's what the labrum does. It just kind of gets stuck in there and it gets injured over and over again. So the most common symptoms for younger patients that have hip impingement, or the technical terms called femoral acetabular impingement, is usually groin pain. A lot of the times I see young athletes that present to me saying, I have a lot of pain when I'm driving in a car and my hips flexed up. And that's the point where the two bones are kind of colliding together and pinching that labral tissue. And that is very, very painful. Usually standing up makes it feel a little bit better. But any type of activity where you're constantly flexing your hip up, those two bones continue to pinch and cause hip pain and labral tears. So the question is, how do you diagnose that? And just like hip arthritis, we start with x-rays. We get x-rays in different views of the femur and the cup of the acetabulum to see if there's any extra bone formed there that's causing that impingement type symptoms. And then more often than not, what we need to do as well is get an MRI, because x-rays only show the bony architecture. To look at the soft tissues and the labral tissue, an MRI helps us identify that. And more often than not, patients with the extra bone form labral tears actually from the hip flexion maneuver. And that's a very common thing that we see in clinic. So, if you're younger and you're still having hip pain, there definitely is reason to have pain from the hip joint besides arthritis, and it's called hip impingement. So those are the two main ones I really want to talk about today. But the other things I wanted to bring up before I let you guys ask some questions is kind of the hip pain mimickers. When patients come to clinic and say, hey, my hip joint hurts, and it's not in the groin, then we start looking at other areas of a pain source. So like I said, it's all about location. The other areas that you can have hip pain are on the outside of the hip. So bringing back my model here, if you look at the ball and socket joint, how they kind of come together to make the hip joint. If I'm pointing right here to the outside of the hip joint on this bony prominence, this is called the greater trochanter. There's a band of tissue that connects all the way up from the pelvis and stretches out all the way over to the femur bone, all the way down to the knee, and that's called the IT band. And what can happen, that tissue can get really, really taut. It's like almost like a guitar string. You're strumming it and it just kind of, almost snaps over top of your finger. And what can happen is that banded tissue can just kind of wigwag over top of that bone over and over again and cause significant pain right here at the outside of your hip. And there's a bursa there. It's a little sac of fluid that can get very inflamed. And that's what we call hip bursitis. So this is probably the second most common thing I see in clinic is the hip bursitis pain. And usually we can figure this out just by a clinical exam. It's mostly on the outside of the hip. If you kind of feel the bony prominence on your hip bones there, you can feel it. And if you're really point tender right there, more often than that, that's from the bursitis. And usually why that happens is from that tight tissue band called the IT band that starts all the way up from the pelvis, stretches out over that bone and goes all the way down to the knee. And it gets really, really tight and kind of just flips over top of that bone over and over again and causes significant irritation. So that is one of the most common things we see that a lot of patients will think it's coming from their hip joint or the groin pain like I talked about, but it's actually more outside. We usually get x-rays too just to make sure you don't have any arthritis that's kind of mimicking that pain, but more often than not, it's usually from hip bursitis. The good thing about hip bursitis is very, very rarely does it require anything but conservative treatment options. Usually what we do is we diagnose it. We get you started in some therapy to kind of focus on stretching out the IT band to make it more loose so it's not like a tight guitar string. And then we'll start doing some therapy to straighten the muscles of the hip. I think ibuprofen is very, very effective. Sometimes Tylenol can help, ice can help. And then ultimately when it gets really bad, what we can do is actually inject the hip with steroid right there on the hip bursa. And that usually decreases all the inflammation and can be curative actually. Some patients respond to that very, very well. I'm just getting a question right now. I'm just seeing if I can answer these here. So there's a question here saying, every night when I'm sleeping, I stretch my right leg and have a lot of pain in the sciatic nerve right next to my hip. This also happens if I sit for a long period of time. The pain's bad and I can't stand up for a few minutes. That's actually my next thing I was going to talk about is sciatica. So I'll bring that up in just one second. Let me finish this other one here. So the other one is, do labral tears often recur after repair? I would say the most time they don't recur, but if they do recur, what can happen is there's inadequate resection of those bony prominences, and what can happen is they continue to pinch that labral tissue that has been repaired. So if you've had surgery on your labrum and it continues to hurt, and if the bone was not completely removed that was causing the labral tear in the first place, they can recur. It's pretty rare. And usually the way to diagnose that is actually doing a repeat MRI with contrast action. That would usually show if you've had a repair that's failed. So that's a great question. And then back to the other question about the sciatic pain. So that's one of the most common hip pain mimickers. So the sciatic nerve is a really big nerve that runs right behind the butt, right in the butt region actually. It's right behind the hip joint. And it's a nerve that pretty much controls all of the muscles and all the sensation to our lower leg, the majority of it. And what can happen is that big nerve runs right through all the hip musculature, and if those muscles get really tight, it almost kind of strangulates that nerve and puts pressure on it, and it can cause pain going down your leg. Most of the time, the pain doesn't actually go all the way down to the foot. It kind of stays above the knee. And that's when I would say we kind of diagnose patients with sciatica. And it's kind of a diagnosis of exclusion after you've ruled out other reasons of hip pain. And if it's more in the kind of the buttock region, more of like a radiating type pain, usually that is from sciatic nerve irritation. And also a good thing about that is it usually does get better with a period of rest, some stretching. Occasionally, like a little bit of a steroid pill can help. We don't usually routinely inject that because it's kind of a dangerous area to put steroid for with a needle going in there because the nerve's right there. But most of the time, it does get better. Just got another question here. What do I recommend for bone spurs? So bone spurs usually are the result of osteoarthritis. What happens when you start to wear out the cartilage of the hip joint? You start to form these bone spurs on the femoral head that can kind of be on the bottom of it, on the top of it, and most of the time those are just a sign of early or even end stage osteoarthritis. So a long time ago, some orthopedic surgeons, before we knew more about it, they would go in there and kind of shave these off or kind of try to take them down. But at this point, what we really recommend if you have bone spurs, you probably have more arthritis than what you really or probably know. And most of the time, bone spurs are treated with hip replacements if you have really bad cartilage wear as well. So you don't really routinely shave those down. The only time you do shave them down if it's a really young patient, like I talked about the hip impingement. All right, just got another one here. All right. The last thing I was going to talk about, and I have a couple more questions I'll cover, is back pain. Back pain is one of the most challenging things to kind of decipher from hip pain. And I'll tell you, most patients with back pain, usually their symptoms are kind of more in the buttock region or in the low back. And what can happen, those nerves can get pinched in the back and shoot pain all the way down to your toes. So if you're having pain all the way down to your toes, more often than not, it's not your hip. So that's another thing will always ask you is your pain kind of start in the butt or the back and go all the way down your toes? And if it is, more often than not, it's your back that's causing that. You probably have a pinched nerve in your back, and we can usually diagnose that by exam and x-rays as well. So that's the majority of my talk. I'm just going to kind of answer a couple of questions here. So one of them says, when is it time to see an orthopedic surgeon for hip pain? I would say if you've had hip pain for 2 to 4 weeks, you've tried like ibuprofen, Tylenol, ice, and it's starting to affect every day, when you're walking or doing those things you want to do and you can't do them anymore, that's when I would absolutely go see an orthopedic surgeon, because usually we can diagnose it pretty quickly. And like I said, more often than not, we actually have a conservative treatment option for you, such as a medication or injection, that'll get you right back to doing those things you want to do right away. So I'd say about 2 to 4 weeks, if you're still having pain, I would absolutely recommend an evaluation. How can I tell if my hip pain is caused by osteoarthritis? So usually, I kind of covered this a little bit earlier, but osteoarthritis is usually that cartilage has kind of worn away, and it's mostly age-related. I'd say if you're older than 50 and you're having groin pain, most of the time that is kind of caused from osteoarthritis. It's kind of a sharp, can be achy as well at nighttime. So usually that's when we recommend an x-ray, and that can diagnose it right away. So I'd say age is a big thing. Your symptoms, if it's a groin pain, that's usually from arthritis in the hip. Another question is, how do I know if my hip has been dislocated? And this is a common question actually here in clinic quite a bit, is that they're worried about potentially hip dislocation. And I'll tell you what, it's extremely, extremely rare for a hip to dislocate. It requires a significant amount of force, almost like a car accident or a bad skiing accident. So if you're just kind of walking around the house or playing basketball, you feel something give in your hip, more often than not, it is not dislocated. And if you dislocate your hip, I've never seen one not have to go to the hospital because they can't walk after, actually. So it's a really, really bad injury, and it's extremely rare. So I think if you're having hip pain, more often than not, it's probably not from a hip dislocation. It's probably just from arthritis, potentially labral tear, that bursitis like I talked about. Can hip pain be caused by a knee injury? I always tell patients, anytime a different joint hurts, such as your hip, your knee, or ankle, the joint above or below it can also be affected. And for the reason because you start to walk a little bit differently. And anytime you alter your gait, it kind of throws off the normal mechanics of your hip, your knee, or ankle. So if you hurt your ankle, you hurt your knee, it can absolutely throw off your gait and actually cause pain in your hip too. And sometimes even if you have some low-grade arthritis, mild trauma such as just altering your gait can kind of set off an arthritic flare. So it absolutely can cause or make a hip injury worse. How can I keep my hips healthy and pain-free? That's a great question. I think more often than not, what I recommend to keep your hips healthy, your knees healthy, is just continued exercise and core and hip and knee strengthening. I think the core is often neglected, the abdominal musculature, and I think the stronger you get your core, the stronger you get your hips. It all kind of is connected together. So I think, whether working out on your own or even talking to like a personal trainer and say, hey, can you teach me some exercise to kind of focus on my core strengthening, some of my hip strengthening, I think that is by far and away the best way to keep your hips healthy. High impact exercises such as running can also kind of cause some more hip pain down the road. So if you're starting to have some soreness, maybe try biking or something that's a little bit less of an impact. What are non-surgical options to help my hip pain? And I think the mainstay of Non-surgical options for hip pain, especially if they're coming from arthritic changes, is usually a trial of like an NSAID such as meloxicam, diclofenac, ibuprofen, some type of anti-inflammatory medication. I think if the pain's pretty severe and it's limiting you to the point you're limping, I would absolutely recommend trying a steroid injection. That can be very, very effective where it goes right to the source of the pain. Again, also, I think just a round of physical therapy kind of to help strengthen the hip and the surrounding muscles can also be very effective. So I'd say those three, medications, injections, and therapy, are usually pretty effective for hip pain. Another question was about hip scopes. What are they and when would I need one? So hip scopes or hip arthroscopy usually is the procedure that I would do for somebody who's a little bit younger who has that hip impingement. It's not necessarily for arthritis pain. It's more for if you have that extra bone form and you're younger on the femur and the acetabulum and those two pieces of bones are colliding. So what we do is we make small little keyhole incisions on the thigh and put a scope in there and take a look at all those bony prominences. And we usually put a shaver in there through another keyhole and we shave down those bony prominences. While we're there, we also usually address the labral tissue where we put anchors into the bone and repair that labral tissue back down. So that usually is a very, very effective way for, I'd say, patients that have hip pain from the hip impingement, but not necessarily from the arthritic pain. If arthritis is your problem, we've studied hip arthroscopy or hip scopes. They're actually not very effective at all. So we don't recommend them for arthritis. It's more for the labral tears and for the hip impingement. Another question was about hip replacement surgery, specifically about anterior hip replacement surgery. So that's the way I choose to replace hips. You can replace them from the front, you can replace them from the side or even the back. All of them are very effective. The reason I like to do anterior hip surgery, I think the recovery is a little quicker. I think patients don't have quite as much pain after. And one of the things that we always worry about when we do a hip replacement is hip instability or that new hip popping out of socket. So when you go through a posterior approach, you have to cut through a little bit more muscle and it lends your hip prone a little bit more to instability. Usually you have to take it easy for about 6 weeks to prevent the hip from popping back out. And it's also very, very rare. But from the front, actually, you don't have to cut as many muscles and tendons. You go through muscle planes. And most of the time, you don't have any restrictions after surgery. So if you have an anterior hip replacement, you can usually progress through your therapies fairly rapidly. I think patients are pretty happy with the results a little bit more quickly. But all in all, both posterior, lateral, and anterior hip replacements are all very effective. So I think you just have to do whatever you're comfortable with. I personally choose to do the anterior hip surgery because I think patients recover a little bit quicker and they don't have as many restrictions after surgery. Got another one here. So there's a patient that had a question about abductor tears or a full thickness minimus and gluteus medius tear. I have been told it's not the easiest surgery to recover from. What kind of activity can I do if I also have lower back problems? So the muscle tear that this patient is talking about is usually where it attaches right here to the greater trochanter. It's called the gluteus medius and the gluteus minimus. We call them the abductor tendons. They're really important muscles that attach right here at the tip of the trochanter. And you can have tears with those acutely or chronically. And what can happen is sometimes they can kind of tear and cause some weakness in the hip. So what you got to do to repair it is you either make an incision or go in there with a scope, identify the tear, and then put anchors back into the bone where it's torn, and then pull that muscle back down and tie it back into those anchors. It's kind of like a rotator cuff surgery. And people often call that the rotator cuff of the hip because it's just like a cuff of tissue that can kind of pull off that needs to be put down with anchors. So usually if you have this type of surgery, a lot of surgeons will protect your weight bearing for 4 to 6 weeks, where they call it toe touch weight bearing, where they don't let you put weight on it. You'll usually need a walker or crutches. And then the thing that you'd have to prevent from happening for the first 4 to 6 weeks is bringing your leg out to the side, or we call that abduction. And the reason why we do that is we want that tissue to heal back down to bone before those anchors pull out. So it's a fairly long recovery, 4 to 6 weeks before you can really start walking and using your leg better, but can be very effective if you have a significant tear. And what kind of activity can I do if I also have lower back problems? I would say for the first 4 to 6 weeks, you would be limited in your ambulation. It might also throw off your back a little bit too, because your gait would be significantly altered because you'd only be walking on one leg. So if you had underlying back pain, I would just plan to potentially have a little bit longer of a recovery just to recuperate from that surgery. Another question I had here is, what different type of injections can you have for hip pain? And I would say that by far and away the most common injection that we do for hip pain is steroid. And steroid's an anti-inflammatory. Our body naturally produces it, and what we do is we put it in a syringe, put the needle in there, put it right where we need it to go, and that it just kind of really helps with the inflammation of the hip. The other medication that we can use is called Toradol. It's another anti-inflammatory medication, kind of like ibuprofen or Advil. It can also be very effective. I don't really recommend doing any type of biologic injections such as stem cells or PRP. There's a lot of people doing these now, and to be honest, there's not a lot of great evidence that they actually work, and they're very, very expensive most of the time out of pocket. So if patients request it, we have the ability to do that here at OSMS. But most of the time, I usually talk patients out of it because I do think there's better options out there right now. Maybe one day we'll have a little bit more information and a little bit more evidence to support that. So I think that's all the questions I have right now. This looks like I got another one here. Looks like that was it, actually. So I really appreciate you guys tuning in tonight. Hip pain can be very debilitating, but I'll tell you what, it's something that can be treated. So if you're having pain in the groin, pain in the buttock region, I would really encourage you to reach out to one of the surgeons here at OSMS. We can usually accommodate people same day or the next day, or we even have a walk-in clinic. If your hip's having a bad day, just walk right in, we'll see it right away. And we can usually try to diagnose that right away and find some type of treatment option that can make you feel better very, very quickly. So thank you very much for joining me. Like I said, my name is Darren Nabor. I'm one of the orthopedic surgeons here at OSMS. And I appreciate your time, and I hope this was informative. And if you guys had any other questions, please give us a call at OSMS. You can schedule online or give us a call here at our clinic, and we can get you on our schedule, help you figure out what's going on with that hip, and get you back to those activities you enjoy doing. So thank you so much. Have a good night and enjoy the summer.